Okay. Deanne's pointed out that there are data sets that we sometimes discover in the inter-disaster period that we didn't know existed. We discover a problem in a disaster, and then we discover there is a data system that may help us. I think Carl has pointed out that the ownership of those data systems has to be mindful of the fact of who they serve. Who do the data systems serve, and what are those populations? Devin's pointed out that there are lessons to be learned in these events, and by improving their process, they can support the inter-disaster development of a stronger plan and proposal. Amy, I loved it, Amy, that there is this notion that the public health department is not an island to itself, and that we can extend and enhance our modeling capabilities, to go to Chesley's point, by exploiting intelligence and capability that may not be within our immediate surround, but we have a way to bring it into that inter-disaster period to facilitate our thinking about the problem. Having said that, let's open the floor for any political statements or questions that people have. So I'll just sit for a minute, and looks like Armand's got his tent up. Is that you? No? Who's that? Oh. All right. Come on, the troublemakers over here on this side of the table. Dan, Rick.
Everyone's tired.
Well, not to be a troublemaker.
Not to be a troublemaker, but to kick us off. First, to say what a rich panel this is. I think that we've had a lot of not only information, but a lot of suggestions, and I appreciate the priorities or the criteria that you brought up. I do want to, as we move into what's new and what would be helping Amy and colleagues, to say that NIH did, and this came after the 2010 oil spill, put in place a disaster research response system where there are some off-the-shelf protocols. And so we can IRB-approved protocols so that we don't have to wait or go through multiple IRBs for some studies, not all the science. So there is that level of progress.
Yeah, I actually was looking at that earlier today. And, I saw, I did a search on like health-related data, and it was really very unsatisfactory. Yeah, I mean, it looked like data from NOA. I mean, it certainly is not like the hospital discharge data.
No, I was specifically referring to protocols, not data. So study protocols.
Right.
Justin, did you want to weigh in? You got your light on.
That was my
Okay, Mike and then Matthew.
So thanks for those presentations. Really very interesting. I'm a big proponent of being able to analyze events after the case so that we can learn from them in the future. But I think one thing I'd like to ask the panel is similar to what I asked the previous one: is what are the questions that we need answers to that these kind of data and analyses can help address? I mean, do we need to know? I mean, I guess I would say is what we really need to know is what happened and why, and what would have happened if things had been done differently along those lines. But that's I'd like to see what you say.
the use case question.
It's the use case question. Yeah.
Deanna, you want to weigh in?
Sure. There's so many questions that come up after these things, but if it's an unknown agent, it's very important to know transmissibility, severity, risk factors, both for who's likely to get sick, who's likely to suffer severe consequences from getting sick, who may even be a node of transmission. So lots of questions around that we don't collect a lot of good information on, to be honest. In H1N1, we had the good fortune of working with Ira Longini, who's I think now at the University of Florida. And he was able in real time to help us with doing some models and forecasts and asking us to collect certain information, including seroprevalence, which we were never able to get anything through. Talk about IRB nightmare. There was just no way we could collect that in real time in such a large jurisdiction. So I would have to say, to get at this R naught, this factor of like how many cases can we expect from a single case, especially during that that inter-disaster period for an infectious agent, particularly for something that is novel and we don't understand well, it can really help us calibrate that next wave. What are we really doing on that next that next wave of disaster?
Can the same thing happen for non-infectious disease?
Yeah, I do think so. The same kinds of things can be applied, like in the case of, we looked extensively. We don't have hurricanes. We're lucky we don't have those. And the things we have are really low or no notice emergencies. So fires come up really quick. There's very little warning, and an earthquake, of course, there's just seconds for the best early warning systems that they're still testing out west. So for those kinds of things, we did look to the hurricane data to see who's left behind, who's really at risk. If you're looking at, the outcomes, if you're looking at mortality data from these various disasters, what can we learn from that? And this that's what really led us to the Empower data, and that is just one data set, but looking at the impacts on people who are older, who have chronic diseases, who have mobility issues, who are electricity dependent, who are connected to cardiac devices and ventilators. Those kinds of things really, we thought we have to apply the lessons from those disasters to these, naturally occurring disasters in our jurisdiction to see how can we assist these people? Is it something that we have to ping their provider and let them know something is coming, like a heat wave that may cause a power disruption? We are doing that now using that data. We have automatic alerting using the Everbridge system that Florida also uses. Can we help prepare centers that people can go to just to plug in to keep them from surging to emergency rooms by flexing up, in some cases, surgery centers who may not be doing surgeries during an emergency. Can we work with the power companies to perhaps build out some resilience centers that would allow people to plug in and be able to maintain their health? If it's just a matter of access to electricity, can we somehow build that out? So Empower's helped us work through that. And right now, I don't know if you all know, in California, as a result of the historic wildfires, the 3 publicly traded utilities are now able to cut power preemptively to prevent fire. But of course, what this means is they're cutting power to all these people who are, of course, dependent on power for staying alive in many cases. So we're working hard. I mean, I never thought I would have to look at electrical grids and backup batteries, and it's the lessons that Puerto Rico had to learn. So a different threat caused us to have to look at this and think, what are the backup systems? Is it getting people out of harm's way? Is it keeping them where they are? What would they need if they remain in place? So I think a lot of the data that comes from these different disasters can be applied to the natural disasters we face on the West Coast that may look different, but in fact have a lot of similarities.
Go ahead, Chancellor.
So I have a slightly different perspective that I hope is complementary. I think there actually needs to be a lot of research or work done to understand the data itself and the aspects of data that we're talking about. What I was mentioning before around standardization. So what are the core data elements for disasters that are not disaster specific that we could bring together people at the local, state, and national level and agree on a set of standards so that we can build those into our data systems and not have to wing it every time we're trying to do this, versus those variables or those types of data that are very disaster or region or location specific. I think that's one set of work that it has been, some people have done that, but I think there's a lot more we could do there. The second is this question to me of the tension between research data collection and action-oriented data collection. We had the experience with the the previous Ebola outbreak in Africa, where one of the tools that CDC staff were using was basically designed for research. When you have small Ebola outbreaks in villages, and people were trying to apply it to a wide epidemic with thousands of cases, and they were trying to collect data on 200 variables, it wasn't going to happen. And so while any researcher could make the case that those variables were critical, it wasn't helping us respond in a timely way. And that tension is a real one. We also don't want to miss the opportunity to collect information that could be used for research, but we're going to have to make some choices about how we do that. I think the other area that I'm struggling with and thinking about how to move forward on is the divide between hypothesis-driven a priori data collection type of research versus the techniques emerging in data science around data mining, natural language processing, and algorithms. And I've had too many conversations where people say, I don't want to mess with syndromic data, it's too dirty, it's too much noise. And yet, I grant you, there is great value in that noise, but it requires us to think differently about how we frame our questions and the techniques we use to explore them. Thank you.
I had a similar question, but I was going to direct it to Carla, since she said during her presentation that we really ought to be thinking about morbidity data and not just morbidity data related to infectious illness, which are data we collect all the time. So I was going to ask you if you've got a list of key data elements that you think, morbidity-related data elements that you think either are specific to a particular type of disaster, that every time there's an earthquake, we ought to collect these 6 things, or every time there's a hurricane, we ought to collect these 6, or a heat wave, or whatever. Or are there some, as was just pointed out, that are actually pan-disasters, that in any event where more than 50 people perish, we ought to collect all of these things?
Well, I think 2 things. One is, I think Chesley's right that it'd be great to have kind of a sort of a standardized set of things that, even though it might be small, that we collect kind of across the spectrum. I think the other point is, it would be really interesting to think about things that are maybe a little bit out of the box. I mean, one of our, so you look at some of our communities last year, even though perhaps it wasn't what we would consider a natural disaster, a bunch of our communities ended up not having a lot of food because we didn't have any salmon. And so some of these smaller communities, some of the indicators might really be around like food insecurity more than they might be specifically health related. So how do we capture things that are sort of in the public health realm versus those things that are health related? I mean, even within the tribal health system, we do have the capacity to collect health related data because, we can mine our EHR just like everyone else can. To various degrees, depending on where you are. But the question then is, and I think sort of across all disasters, and I think this was partly pointed up in the Puerto Rico hurricane as well, that a lot of these communities already suffer from a lot of poverty, a lot of unemployment, a lot of issues around the social determinants of health. And these have a huge impact on the health of the community. So what are some indicators that we can collect in essentially real time that can help us, and then maybe longitudinally, sort of understand the impacts of disasters on these communities and how we might better address those in the future. And I think that Amy did some research with the behavioral risk factor surveillance system, which all the states do collect. The problem we have in Alaska for that, and this is true of a lot of tribal communities as well as rural communities, we can't get those data at a level that's relevant to the community. And in Alaska, we oversample. We spend, some tribal dollars oversampling in our rural communities so that we can at least report it at sort of a regional level. So it's thinking about how we can better support those systems so that they're more relevant at a smaller level, and then also maybe develop some indicators around some non-traditional public health related activities like food security.
Can I just sort of follow up? Because I believe our charge precludes us from looking at syndromic surveillance and sort of routine surveillance. But one of the things that's becoming clear to me, at least, is it's going to be hard to do a good job of knowing what the difference was when you had a disaster if you don't have the baseline data collection system to start with, because it's always going to be a delta for these kind of things. It's not that there's suddenly a bunch of people had Hep A and they never had it before. It's that there was a baseline rate and it increased. So there, it's going to be hard, I think, for us to separate completely syndromic surveillance or
the task says we have
surveillance.
we're looking and focusing on those threats that lead to a Stafford Act declaration as sort of the way the task is defined now. That sort of moves us away from routine infectious disease, but if we had a pandemic, that would certainly be a Stafford Act. But in general, I think your point is correct. It's how do we use syndromic surveillance, which is useful for the planners to understand what's going on in their community.
Yeah, and it's more than syndromic surveillance. Where I was going with that is the stuff around social determinants, right? So if we want to know that people had greater food insecurity as a result of this disaster, we're going to need to know what the level of food insecurity was in the community before the disaster.
Sue, did you have yours up?
I did, but it mostly got answered. But just to add a little bit to that, specifically to Dr. Britton, I'm really happy to see any mention of tribal nations at this committee, so that's really great. But I'm thinking you probably work with some of the hardest to reach populations, perhaps in America. And I'm wondering, in the event of a disaster, in thinking of real-time data, what sort of mechanisms and systems are in place in populations that I imagine might even be cut off due to weather or whatever for periods of time.
And I think Alaska is really unusual, and I think we should think of some of these things in sort of more of a rural kind of context anyway, not just Alaska, because you're right. I mean, Alaska populations, our communities are really small. In bad weather, they're cut off. Sometimes communications can be cut off. I mean, last year, just as kind of a general thing, it was really icy, and one of our communities sort of lost all its internet communication, which now is really 21st century, right? Everybody has social media. We now call what used to be sort of VHF radio, which is a way our communities communicate within them. We call it EVHF, which is Facebook. But the question really became is how do communities whose cellular towers completely iced over and can't really communicate with the outside, so there has to be some community resilience to deal with it. What happens when they run out of fuel for the generator, which provides the power, or even something as simple as a small part in that generator breaks and you just can't get it to them. So they actually have some resilience around those that maybe larger communities don't have because it's something they experience more often. But for them, the bigger question is, how do you deal with flooding related to climate change? I mean, we don't think of that as a natural disaster, but the flooding itself we would kind of work with, but the reality of it is it's likely to increase just based on some changes, and how do you deal with that? So that's kind of where those social determinants of health kind of come into what's the long-term result of something like that on the community when your community is slowly disappearing into the sea. So, but yeah, Alaska is unusual. But I would think a lot of these things think about it across the U.S. in small rural communities where, even though you might be able to reach them, where they still have a lot of the same issues. Particularly in terms of data, you just can't. There's just the opportunity to get data at that level is actually really hard.
I'm not sure what the sequence was there. Ali was up first.
Thank you to the panel. You're a good reminder that just like public health, data is the lifeblood to a response. And good quality data, obviously. So my question is directed to Dr. Richard. So Chesley, always nice to see you. I agree with you wholeheartedly that technology isn't the solution, and probably except for thinking about on real-time surveillance of excess mortality and probably rethinking our terminology for direct and indirects. We have some other thoughts have been going around rattling in my head. But so what is it going to take? If technology isn't the issue, we take that off the table. How do we get states to have electronic mortality reporting systems, electronic medical examiner, coroner's reporting systems, syndromic surveillance? Most already have syndromic surveillance electronically. How do we get them to link together? And I think I'll ask the same question for Dr. Schwartz, who's tomorrow going to talk about NCHS. What can CDC do to help make that happen in the state, help foster those relationships in the state for these systems to be talking to each other?
Well, I think the good thing is that I think that it's happening. And I think what it's taking is leadership, certain policies beginning to line up, certain external factors, pressures, if you will, and some good use cases and some good successes. So let me give you some specific examples. With syndromic surveillance, and you were key to that, in your time at CDC, that program has grown, and now we get 2/3 to 70% of all the ER visits on a daily basis into a national cloud-based data system that states can access in their lockers, and we can look at a national level. That's a success that we don't really talk about. Where we need to take that is we need to do more science with it. We frankly need to understand the noise, because I still get this complaint that it's just noise. Well, it's not. And a great example was our local syndromic surveillance coordinator in our program, who had come from Georgia, noticed a signal in Georgia for carbon monoxide poisoning. He didn't know anything. He just saw the signal. So he went and investigated. He called one of the epidemiologists up at the health department, and they looked into it, and there was a school bus in a county that had a faulty exhaust system, and 20 kids went into the ER with carbon monoxide poisoning. So that's not noise. That's a real signal. And we've got lots of stories like that. So that's a success, and it's building, and I think our next phase is to really do more with the science to understand how we can make the most of it. A second example has been what you've heard around mortality reporting. In 2010, less than 10% of the mortality reports in the country came into NCHS within 10 days. And with Charlie's leadership and Delton Atkinson and now Steve's leadership, that's up to about 70%. And we're able to use it for things like influenza death reporting, where there had been an existing separate system for 50 years that Dan Jernigan in the flu program was able to take down. We're using it for opioid reporting. Instead of building siloed systems, we're using both the syndromic surveillance and the mortality reporting to get the data for the opioid reporting. And we've got that down to a 6-month delay for mortality, and we'll probably get it even closer. So there are some important things happening. But there are new partnerships we need to develop. One of the most recent ones that we're beginning to have some success with is the Digital Bridge effort. This is an effort that has included the largest EHR vendors, Epic and Cerner, as well as others. It has included the AMA. It's included the public health organizations. It's included a variety of other partners. It's been funded by the Robert Wood Johnson Foundation and now the CDC Foundation. And we've been able to come together and agree that there are a set of about 50 variables from every EHR that we should be able to get most of the information we need for notifiable disease reporting in real time without interrupting physician workflow. And we piloted it in Utah, Houston, and New York City, and people are astonished at how much information they're getting in real time. So there are some successes, but we need to build on that. And the next thing that needs to happen is we need to be able to have dedicated infrastructure resources to be able to scale some of these and connect them. And I spent a long time at CDC, and I'm sure most of you who have been in some level of government service know that infrastructure doesn't sell. But I tell you what, it's begun to sell. We have 3 bills before Congress for funding of up to $100 million a year for several years to build infrastructure around data and analytics. And that's because we've been able to build a coalition of people who have said, including our director, we have really got to invest in this infrastructure or we're not going to be able to do our job. Now, is that all that it takes? No. But if you have a core infrastructure with some of the characteristics that we've all talked about, then your programmatic funding, whether it be federal, state, or local, can go a lot further and get information in disasters or other public health issues that we can use more effectively to have intervention. So I'm hopeful that we're on a path to be able to do a lot of this.
Perhaps no questions, but some other issues that are going on that will build on what Dr. Richard said. First up, going to the inter-disaster baseline. For better or worse, many states did not have a system in place that could provide us what that baseline is, but yet there are daily systems that collect information that can be used as an inter-disaster baseline. And so there are nuggets under our nose that we need to your point, Dr. Richards, use science to look at that data and overcome the worry about the noise to be able to create that baseline inter-disaster so that we can look at the difference. So that's one. Secondly, we haven't heard the word yet or the term yet today, so I'll introduce it. We've talked about the social determinants of health. We did not talk about disparities yet. And disparities and disasters often go hand in hand, at least the impact of those. And so for us also to focus on, in the example of food insecurity, both the proximal and the distal influences of disparities that then ultimately impact the how communities survive or how communities suffer during disasters is important. And then I would want to mention an NAS report very recently on measuring community resilience. In that report, there is a framework how communities can build and strengthen their resilience, and it looks at the 6 capitals, including social capital, political capital, financial capital. So I recommend us to look at that as a way to address and a way to measure disparities.
Really good comments, but let's get down to specifics. You know, we're going to be coming up with some recommendations, and the last thing we want to do is go against some of the things that you're doing right now. And I'm just thinking of some specifics. For example, you talked about hopefully getting some funding to really streamline and bring together all the surveillance systems within CDC. And you mentioned about having maybe some core information that might be collected if we figured out what that might be. I'm concerned, and I'll give you several examples. Is that system then going to be nimble enough to then allow us to add certain questions to it, certain data items to it in times of emergencies that are declared? Number 2 would be, another example would be, we are doing surveys throughout CDC. BRFIS is one, HIS is another. Is there any chance that those maybe could be utilized during a time of surveillance? There's also, not under CDC's control, but the American Community Survey is another that could that, in fact, mechanism be used from a federal perspective to help in looking at what some of the issues are involved in areas with disasters? We were listening a lot of times to electronic death registration. It seemed like things are going very well, but not with a whole lot of standardization. I think NCHS is getting funding through the opioid dollars to help states with their electronic death registration. Are there, can there be standards in there that require them to have pop-up boxes, flags for during disaster times, or they don't get the funding for it? Things of this nature. Or are these types of recommendations going to get in your way?
Well, Charlie, as your former supervisor, I was pleased to hear earlier that you were alive and well. I think I don't want to be too presumptive about it because the committee obviously has to do the work that it has to do, but I think the things that are important to the efforts that we've been doing, and I think from what I've heard here, are, one, that resources need to be put, however they come, the resources need to be invested not once or twice, but they need to be continually invested in a data infrastructure if the country's going to have that. And that's for disasters and for other things, but particularly for disasters. That infrastructure has to be one that has a certain amount of standardization to occur, but again, allow enough flexibility for the various use cases that are very different that we've heard. And that's a hard thing to figure out. I don't think you can make a recommendation about where to do that, but what you can recommend is that the process of going there is one that's inclusive. It's inclusive at a federal level, a state level, a local level, a tribal level, a territorial level. And we do need a process where we really make some decisions on it. One of the things we've done at CDC in recent weeks is we've revamped our governance around IT and data because we, like many organizations, had a governance where people came and talked to each other, but we never made hard decisions. And so now we've instituted a governance that's going to do that. And I think at a national level, we're going to have to think about how to do that. So those types of recommendations, I think, might be helpful. I think the other recommendation I would say is that we've got to get serious about having an information and data infrastructure that's digital, that's real-time, that doesn't have to pass through a lot of roadblocks in order for the data to flow. And that happens in many other non-health sectors, but it's particularly hard in the health sector for all the reasons that we've talked about today and the ones we haven't talked about: privacy, confidentiality, data provenance, who owns data. Yeah, what's protected, what's not protected, why isn't it protected, shouldn't we protect it? But I think when I think about the possibilities of, for example, an electronic death registration in which there would be real-time clinical decision support for a clinician to figure out the right thing that this person died from, that's connected to a funeral home, an electronic death registration system. That report flows to the state to who it needs to. It flows to CDC to who it needs to, and it's ready to be used in 24 hours, 48 hours, for whatever purposes we've agreed that it should be used for. Now that's a real system. A system where a piece of that works and another piece of that works, but there are big blocks in between, is not a real system. And so I think if the committee had recommendations about getting real about real systems, I think that would be helpful to reinforce some of the things we're talking about.
And I think to your point, I think it's also the across-the-board system. It's not a system that 10, 15 states are able to implement and put in. It's a system that's able to be used by all jurisdictions and vital records. I think that's the...
Tribes.
Including tribes.
Thank you.
Thank you. This is probably more of an observation/comment, but you all might have some thoughts to it. I think, Craig, you asked earlier about rural communities, and the discussion around Alaska just kind of prompted me a little bit. I think some of your comments about Alaska actually probably generalized to a lot more rural communities. We recently completed some work with colleagues from Texas, looking at Texas, North Carolina, Northern California, and you know, when the one road, even if it's interstate highway, shuts down for a week, it's cut off, period. And, when the Northern California rural communities were very concerned about the power being cut off for a week, and they had no idea what they were going to do, because there's one nursing home in the community, and where are those people going to go? So they're very concerned about that. And it raises some of the disparities questions, the social determinants of health issues. All those people you talked about that need that you identified through Empower, as well as probably others that you can't identify through Empower because of the nature of the data sources. Capturing that information, it accelerates, exacerbates those trends, and changes those communities forever, because a lot of those people who end up leaving don't come back, especially the younger ones or the workers. And so what impact does it really have on the communities? Just briefly, we also kind of touched on the race ethnicity data. Even an organization like the VA has lousy race ethnicity data, and we ask people to put it in themselves, but that data doesn't go from here to the rest of the records, et cetera. So we can't answer some of those disparities questions if we don't even know something as basic as what's your race or ethnicity. So I don't know. That's probably enough.
I think they're all good points, and yes, the issues from Alaska really do the issue of rural America and how things impact the rural communities is something sometimes we not forget about, but sometimes it's harder to see just because the populations are smaller, and probably also because there aren't as many hurricanes, which are just a regular and recurring event, and I think that's. Another question, too, really is how do you deal with things like hurricanes, which happen all the time, and things that might be a little less recurrent, but still really important and valuable? And how do we collect data about those, too? Earthquakes.
Can I add, too, that we're working with the state to get Medicaid data, just like we're getting the Empower Medicare data from the feds. So Kristen Finney at Asper has been very helpful in those negotiations. We're also looking at children's medical services data. We just met with our Department of Public and Social Services to get at people, to get some of those baseline numbers and to start working with them on flexing up. They know exactly where their clients are and what their day-to-day needs are, and we can expect there would be additional needs after a disaster. So I think, we're doing this piecemeal, this is how the data is. So we're dealing with the realities of that and getting that information. On the back end of this, we're also working out real operational protocols with each of those cities. So 88 cities, where 38 of those are in high fire zones. So we've negotiated the biggest protocol and data exchange agreement with the biggest partner, LA City, which is half the population. So we're going through to each of those cities and negotiating with each of them. Would it be nice to have some sort of standard and have just be a one-stop shop? We're always so envious of New York because it's one city, fire, one PD. That isn't the way it is in Los Angeles County, but we know the realities of that, and we're just, chipping away and making sure that we know who these people are, and we know what their needs are, and we have plans in place to make sure they can be helped.
Yeah, a couple comments. So, it seems like we have sort of two parallel conversations going on in part. And, one is about data infrastructure and ongoing reporting and recording systems and strengthening them. And that seems like it makes an enormous amount of sense and is a lot about what our charge is to do. And then a second thing about all the other kinds of data that we need and how we might get some of that. And I do think trying to come up with creative ways to harness ongoing surveys makes an enormous amount of sense for that. Whether it's ACS or BRFIS or HIS or NHANES, coming up with a way to try to take one of those that has some good data on both affected populations and unaffected populations and turn that into sort of a longitudinal resource is going to help you do a bunch of different stuff. One is get at some of the nuances and the interconnections across things. So how does economic stress on a community turn into mental health consequences and chronic health consequences, a bit down the road. So you could take one of these things and turn it into a longitudinal resource, which would be incredibly helpful. And I think one of the reasons that's been really hard to do is this lack of trust. It's not totally clear to me the different actors and agencies that one needs to build that trust across. But I think if that were there, you could respond much more quickly and maybe even with some forethought, into how to build build something that is not an ongoing regular reporting infrastructure, but is almost a special needs application of techniques. And then the last thing I want to say about sort of the rural issue is it seems to me that in a lot of different parts of the United States, there are populations that have this really deep connection to place, and they're not going to leave those places very easily, even as those places change, as a function of climate change or this recurring frequency of natural disasters. The population densities are a lot lower there, and so characterizing them well with our current systems is not super easy, but they're awfully important in terms of thinking about the next 50 years.
Thank you for that, Elizabeth. That was a very nice summarization in many ways. I mean, as I said at the end of the last meeting, the whole business of, tribal survival versus individual aspiration is something that those of us that live and grow in Indian country, that's an internalized reality for us. And I think it is for some barrios in Puerto Rico and other communities like that. But in the wider environment, that's a harder sell, and that's what Chesley is up against, but is seeing progress towards, and that is we collectively have issues at stake here, skin in the game. What are we willing to engage collectively to do that? I mean, this is a problem I had in Asper, because I'd go to New Jersey and they've got their Hippocrates system, and I'd go to, California and they had their system, and I'd go to this one and they have their system, and I'm going, holy crap, why can't we have a common language that we can talk? It's the same problem I had with the 5,000 docs I had in Indian Health Service when we had to do GIPRA. How do we take this electronic health record and abstract out the most meaningful indicators of whether the health is well, we're doing the right things, et cetera? And this is the challenge that we have in front of us with data sets. What are those data sets? Who owns the data sets? Are they willing to play? What are the end users really looking for, as opposed to an abstract hypothesis generation thing that we're working on? These are the issues that we're confronting. And the panels that we've heard today really have brought all those issues to the fore. There are lots of data elements out there, some of which are purely health, morbidity, mortality, some of which are health-related, food security, social determinants. Those all play. We're charged to look at morbidity and mortality, but it's hard to do that without thinking about these other realities as we think about how it applies in a disaster reality. And so the discussion today, I think, really exposed there's a lot of progress. We've made improvement. We're adding technology to the system. People are getting a better sense of what it is that's important to them. We've learned. We've been burned a few times, and we've learned a few things. But this is what we're going to be struggling with as a committee going forward, is how do we respond to some of what Chesley has said. Well, we've heard the end users say they're looking for. And Mike, I know they didn't say specifically, I need this data set for this particular use. And I have some difficulty with, we don't have that answer yet. But in some ways, I guess we'll just push back some of our ideas to these end users and say, is this getting in the ballpark? But, so, I'm sorry, Madam Chair, I just am, we've had these 4 panels and these guys are ending the day, and it just felt like I needed to say something.
It's a great summary. I think, Richard, you want to say something, yeah?
Just quickly, because I don't want to let it pass. In one sentence for each of you, what do you see as the biggest barrier to accomplish, Chesley, what you wanted to get done? Just to do it in one sentence. What do you see as the biggest barrier? Because that's going to help us get to the solution.
Let's start over here with Deanne.
Well, I think it's going to require a changing of the guard. There are people that feel the systems are working. Why mess with them? So I would say there has to be leadership and a big vision to think about how to do this in a way so that these things run in the background and they don't require specific human intervention.
Only get one sentence. Enough resources to reach down as far as the data needs to reach.
I think the buy-in as well as the flexibility of the system to be able to meet jurisdictional needs as well as the needs of the data users.
We developed an approach and a lot of skills while we were funded, and now it's just sitting around, waiting to be used again. So continuity of funding, at the health department so that they can, expand as needed to do some of the work that needs to be done. And apply it.
I thought of 3 words, but I'll only use one. Culture.
What were the other 2, just curious?
Trust and urgency.
Well, I think that's a great note to end on. You've given us, the committee, a lot of food for thought. It was a fantastic panel. All the panels were great, and I think yes, clap. Would like to thank all the speakers today, as well as the moderators, for a really good day. At this point, we're going to adjourn the public session. I would invite all our guests, visitors, to join us back here tomorrow. We're going to start at 8:30, am I correct?
Yes.
With breakfast available at around 8. And we'll go till about noon tomorrow. So I hope you'll be able to join us back here. For the committee members, your job isn't over yet today. We're going to give you a 15-minute break, but then we'd ask you to come back. We'll have a short closed session and then on to dinner. Okay? Thanks.